Welcome to Let's Talk Micro.
Hello, dear audience. Welcome to another episode of Let's Talk Micro. As always, I hope you had a great week. And you can always find Let's Talk Micro on Apple Podcasts, Spotify, Amazon Music, Goodpods, wherever you listen to podcasts, you can find Let's Talk Micro. As far as social media, I am on Instagram, TikTok, and YouTube as Let's Talk Micro, on X as Let's Talk Micro 1, on LinkedIn as Luis Plaza, and I have an email address which is letstalkmicro@outlook.com. So either via social media or via email, you can reach out with any suggestions, any feedback. They are always welcome and appreciated. So please go ahead and subscribe to the podcast, download episodes, and if the app allows you to do so, please go ahead and leave a review. Thank you so much for the support. And as you know, the Let's Talk Micro podcast is not sponsored by anyone. So if you want to support it in any way, you can do so via Venmo link or via Buy Me a Coffee, KO-FI. Both links available on the show notes. If you haven't checked out the previous episode, please go ahead and do so. It was a great episode with Dwayne Newton. And Dwayne is a microbiologist. You know, he was trained as he has a PhD. He has a lot of training. He ultimately was a director. And then he started experiencing some feelings, and he actually describes it as being miserable. And I listened to him give a talk at First Coast ID in Jacksonville. And in the talk, he talks about, he shares his journey. He talks about those feelings, what did he do to change those? So I invited him to the podcast and he joined us and then he shared his story. He also gave some advice on how you can navigate your own path. And this is something that I know maybe most of us, if not some of us, experience at some point in our careers, where maybe we feel that we can want to do something different, or maybe we're at a job that we don't feel fulfilled. Maybe you might be dreading going to work. I talk a little bit about my story. So definitely in the episode, Dwayne gives some great advice and it's good listening to him. And it's also, at the same time, it gives us perspective of how similar we all are. So we are all human. And we go through these feelings, regardless of the training, of the education that we have. This is something that happens to all of us. So I hope you check it out if you haven't already. And as always, if you are looking to learn more about antibiotics, please check out www.learnantibiotics.com and the Learn Antibiotics book available on Amazon. These resources include cheat sheets, practice tests, games, and more, and they are being used by thousands of people worldwide and may be helpful for you or your colleagues. Great resources from Dr. Timothy Gauthier, a very passionate pharmacist. And speaking of antibiotics, this week's episode is the next episode of the AMR sub-series. So of course, in this episode, Andrea Princey joins me as the co-host. And this time we'll bring a guest as usual, and we talk about polymyxins. This might be one class of antibiotics that you might not be too familiar with, but definitely if you work in the lab, you're familiar with colistin. At some point in time, maybe you have either worked with it, or if you have an MDR organism and you don't do any reflex testing, you might send it out for colistin. So at the very least, you might know about that. So as always, we tackle those great questions, right? Mechanism of action, intrinsic resistance. We refer to CLSIM 100. And as always, the great question, whether we can apply the interpretation of one member of the polymyxins to another one. So all in all, great content. I hope you enjoy it. It's such an important work we do on the bench. And knowing this, it really helps us to do our job better, having a better understanding. So I hope you enjoyed the episode. Let's go ahead and listen to it. So, as you know, in the Let's Talk Micro podcast, we have the AMR series where we really break down antimicrobials. And today we're actually doing the next episode on the series. So, if you really enjoy this episode, so today it's your lucky day, but I always invite you to definitely check out the other episodes. So, with me today, as usual, when I'm doing the AMR series, I have my co host, which is Andrea Princey. Andrea, how are you?
Hi, Louise. I'm doing great. How are you?
Pretty good. I think my summer class just started last week. So it's not as bad as one credit. So it'll be a little bit easier this summer, and then I really have to push in the fall with 4 credits, but that's the end of the road.
Oh my gosh. Wait, which one are you doing this summer?
It's a journal class, so every week we have like one paper that we have to read and discuss, and then cite other literature, and it's like this whole format, citing your sources and telling your opinions, and we also take a quiz. So there are no actual exams and no other projects, so it's a little more manageable with things that happen in the summer, like traveling and things like that.
Oh my gosh, Luis, I love that. Actually, just a sidebar on that. That is like, to be honest, I would say that's probably one of the most useful skills I ever learned in any of my courses. And our guest today could actually comment on this down the road later in our episode if it's relevant. But I run a lot of journal clubs and things at work and otherwise because it's really hard to read a paper well. You know what I mean? And like really break it down and understand all the elements of a published paper and what you need to get from it and all the methods. And so I think that's wonderful that you're doing that. I think that's such a useful skill.
Yeah, and then we had to like do some type of reading, some sort of another classes, but this one, yeah, it's really like telling you how to actually read it, and it tells you things like start with read the introduction and then jump to the conclusion, and then after that, kind of work your way back and checking if what they're stating at the end, and then it's what actually it's been detailed in the paper, so it kind of helps you because yes, it can be a little overwhelming, and you click on that thing and you see like 17 pages, and I'm like, oh my goodness, so it's kind of good to stay organized. And
That's great. It's not easy to really read a paper, really. Like, I think that that's an art that has been lost on some folks. So I think everyone should try to do some additional training in that. That's really great. You're so awesome, Luis.
thank you, I appreciate that. I always appreciate your support, and it's really I'm always grateful for that, since the early days of the podcast, which actually just turned 3 a week ago.
Wow, 3 already. Congratulations.
Thank you so much. And everything okay with you?
Yeah, great. Had a birthday, as we know from the last episode. So I feel a little older. I don't know if I necessarily feel wiser. I definitely feel older. Just busy otherwise, doing lots of micro in the world.
Definitely. Well, with this type of series, of course, we always have a guest that helps us, talk about the antimicrobial group. And as I said to the audience, if we're starting this series going over the different classes, really breaking them down, and then later on we'll jump on some other topics. But with us today, we do have a guest. So, Andrew, you want to go ahead and introduce our guest?
Yes, I would love to. Today we have Dr. Alyssa Walker, who is also a very, very good friend of mine. And lucky me, she lives in Colorado with me. So I have her wonderful, positive, smart energy near me in the state, which is fantastic. She's going to be talking to us about polymyxins today, which admittedly is the group I know the least about. So I'm really excited to learn something from her today. She is a medical advisor at BMRU, and she is focused on infectious diseases. She discovered her passion for infectious diseases in a microbiology course during her undergraduate education and pursued this interest during graduate school through a student research position focused on the pharmacokinetics and pharmacogenomics of antiretroviral agents. She obtained her PharmD from University of Colorado School of Pharmacy, and her PGY1 pharmacy practice residency at Lutheran Medical Center in Wheat Ridge, Colorado, and her PGY2 infectious diseases residency at Boston Medical Center in Boston, Massachusetts. Alyssa has over 10 years of inpatient hospital experience and during this time pioneered a multi-system antimicrobial stewardship program. She's just totally awesome. Alyssa, welcome. Do you have anything you want to add to that?
Hey, thank you so much for the warm welcome. I'm just really honored to be here with both of you. I wanted to say, Luis, I really admire what you're doing here with this podcast. I think it's fantastic. I am a listener. And also, I think it kind of takes me back to my days in the hospital. I had a really fantastic relationship with the microbiologists. I was down there every day. I can't even say how much I learned from all of them. And I have actually still lifelong friends. I'm no longer at the hospital, but still keep in touch with many of them. And I really felt like when we worked together and communicated as we did, we drastically improved patient care at our hospital and really at our IDN. So I just really love the Clan Micro community. I love what you're doing. I love this podcast. And especially this series, I think it really just touches on several things I'm passionate about. So really just the importance of reporting current and updated MIC breakpoints. And then today, since we'll be talking about the polymyxins, they really do have a soft spot for me. They are a bit in the doghouse, and we'll get into that. But when I graduated from pharmacy school, it was in the midst of the polymyxin revival, is what I like to call it. So it was before we had these novel beta-lactam inhibitors. We really didn't have options for multi-drug resistant bacteria. And so polymyxins were kind of coming back to life, and we were exploring how to use them, how to dose them. So just really excited to be here today with both of you and talking about a drug class that is important to me.
Thanks, Alyssa. I know Luis and I, we love all the love from our PharmD colleagues on these episodes, right, Luis? Never tired of that.
No, definitely not. I think it's just, yeah, it's always, great. And as I say over and over again, because I do enjoy it, and not only enjoy talking, but also meeting so wonderful people, and all the guests that I have been fortunate enough that they have said yes to the podcast. They have been wonderful, and so always positive experience. So Alyssa, it's definitely a pleasure having you here, and I appreciate that you said yes.
Thank you.
So as Andrea said, definitely, and maybe from the medical lab scientist, also a point of view, maybe, yeah, with the polymyxins, those are maybe one of the ones that we might not know much about. We definitely know about colistin, and you'll talk about that. And you mentioned the revival, and that's something that I learned when I was taking another class. We definitely, when we're going through the program, we definitely focus on beta-lactams, and we learn things, like ESBL and things like that. But other than that, we don't touch much on those. So it's definitely great to finally get a chance to break them down and learn about them. So maybe can you start with, we love our historical overview and things like that. Maybe you can share a little bit of history about the polymyxins and start things off that way.
Yeah, I'd be happy to. So the polymyxins were discovered in 1947 from Bacillus polymyxa. So it's a bacterium found in soil. And they are amongst the oldest antibiotics that are still in use today. However, they do have a very turbulent history, a bit of a roller coaster as to their use in clinical practice over the last 70 years or so. So after their introduction, they really kind of took off in that they fit a niche where they were treating gram-negative bacteria where there wasn't other options. However, in around 1970s through the 1980s, they really fell out of favor due to profound nephrotoxicity. And then at that time, there was also an availability of other anti-pseudomonal aminoglycosides. So they did continue to be used topically as well as agricultural use. However, between early 2000s to like 2010, we really saw a revival, kind of depending upon where you were in the world, due to the emergence of multi-drug resistant gram-negatives, so multi-drug resistant Pseudomonas or carbapenem-resistant Enterobacterales. There weren't other drug options, so we were looking back, and we used to call it our toolbox, like what are the older agents, and do these possibly have activity against these new multi-drug resistant bugs we're seeing? And so there was this resurgence in research around how to dose them appropriately, which we really didn't have a whole lot of data on. And so when I was coming into clinical practice, we used them a lot. But really in the past decade, we've seen several beta-lactamase inhibitors come to market that are active against multi-drug resistant Pseudomonas, carbapenem-resistant Enterobacterales. And they have demonstrated vastly superior efficacy when they've done head-to-head studies of polymyxin or colistin versus this new beta-lactamase inhibitor. And then when you layer that on top of the really profound nephrotoxicity seen, particularly with colistin, they really, again, have fallen out of favor, and now they're considered a drug of last resort, reserved for multi-drug resistant infections when you have no other agents available.
Alyssa, can I ask a clarifying question there for the audience really quick?
Absolutely.
That's a really great description. So when you say nephrotoxicity, you mean damage to the kidneys, right?
Yes, absolutely. Yes.
And so can you explain that from just very briefly, high level, like nephrotoxicity with certain drugs is a challenge, right? Because any way you dose it, if you're dosing it at a level that's high enough to maybe kill a bug, you might be causing kidney damage. Is that how that works? And was there any way to get around that with these drugs, or was it just kind of, it is what it is?
Absolutely. So this is a great question, and something that was that clinicians ask every day, and when we try to use these drugs when we don't have other options. So colistin in particular, we kind of lumped these together saying polymyxins or nephrotoxicity, but it is a bit more nuanced. So colistin in particular really concentrates in the renal tubules, and so it's basically causing cell damage. And what we've seen is the concentrations that are required to kill these bacteria are basically overlap with the concentrations seen with nephrotoxicity. So when we try to use these lower doses, we don't see efficacy or bacterial killing. So that's really the problem, is that we're pushing doses to achieve bacterial killing. However, then we see the nephrotoxicity. So as we saw more and more data coming out with these, we started to see a trend in that maybe the nephrotoxicity wasn't actually associated with polymyxin. And so really today we kind of consider this the safer agent, which really wasn't known when I came into clinical practice, but it really has, for that reason, in some regards, become more of a favorite. And we can get into more of those details later. But polymyxin, generally considered low to no nephrotoxicity, colistin, highly nephrotoxic at therapeutic concentrations when it's given systemically or basically IV. Yeah.
Interesting. Okay. Thank you.
Yeah.
Yeah, thank you for that. And that's definitely a great question. So just to put it all together, so we talked about polymyxin, we mentioned colistin. So which drugs does this group include?
Yeah, absolutely. So it's the lipopeptide class, and I mentioned there's polymyxin or polymyxin B, and then there's the probably more vastly known colistin, or its other name is polymyxin E. So is actually something that just came to market as I was looking and researching for this podcast, upaglanin. I probably butchered that name, but it's a new polymyxin analog that's showing some promise for multi-drug resistant gram negatives. And they're really looking into this drug class to see if we can leverage its unique mechanism of action and limit the toxicity. So currently today in use, polymyxin B and colistin or polymyxin E.
Okay, thank you for that. And one thing that we definitely like to do in this series is talk about the mechanism of action. So for this group, can you talk about the mechanism of action?
Yeah, absolutely. So the mechanism of action for the polymyxins is that they disrupt the outer bacterial cell membrane. They're often referred to as a detergent, and I remember hearing that actually in pharmacy school, and I thought, what? Instantly got my attention, and it kind of stuck with me. So really the reason why they are labeled, or often you'll hear this detergent mechanism used, is that because they're disrupting the bacterial cell membrane, it's likened to how detergents would break down grease and oils. So that's kind of how they got named that. So it disrupts the outer bacterial membrane, the lipopolysaccharide outer membrane of the gram-negative bacteria, and causes cell death, basically cell lysis and cell death.
Okay. And as far as for the organisms that this group treats, we talked about that it was brought for MDR gram negatives. Can you give a few examples?
Yeah, absolutely. So it is intended it really does treat a broad array of gram negatives, but the intended use today is for multi-drug resistant gram negatives, as you mentioned. So multi-drug resistant Pseudomonas, or really maybe a better term today would be an XDR. So it's resistant to, basically pan-resistant to the available agents. Another bacteria we see it used for where we often have no options is Acinetobacter. And then potentially the carbapenem-resistant Enterobacterialis, if you happen to not have one of the other agents available, whether that's drug shortages or other reasons. But we do have more agents available for those generally.
Okay, and one thing we always direct the listeners to the Appendix B of the CLSI, well, the whole document in general, but for intrinsic resistance, which is something that I like to ask, we always ask the listeners to please go ahead and check out the CLSI 100 and go to the Appendix B and get familiar with that. So for this group, is there an intrinsic resistance?
Absolutely. And I will second that. I loved my M100 document, still do, but it was basically my Bible in clinical practice. The tables in there, the footnotes, just a wealth of knowledge in that document. So yeah, as I mentioned, so since it does target that LPS containing outer membrane, that's not present on gram-positive organisms, there is intrinsic resistance basically across the board for any gram-positive bacteria. There are some notable holes for the gram-negative organisms. So the intrinsic resistance for gram-negatives that we'll see is with Morganella, many of the Proteus species, Providencia, and Serratia marcescens.
Thank you for that. And one interesting fact for the audience, and I always like to ask them, especially if you're working on the bench and get familiar with your media and things like that. And one popular media that we use in the lab that actually has colistin, it's modified Thayer Martin. And it's also, of course, it is used to inhibit the growth of most gram negatives. And it also has trimethoprim. So even though Proteus can technically grow on it, it doesn't swarm because of that. So I don't know. This is a cool fact, and I always like to tell my students this in the audience.
Oh, that's great. I'm just over here. I'm like, the detergent thing is really fascinating to me. And of course, as I said, I really didn't know that because I don't know much about the polymyxins. And I'm just thinking, wow, that's so interesting. So in order for organisms to be resistant to this class, they either have to not have LPS present, right? Or they have to have some modification to their LPS in order for this drug not to work, which I think is so interesting because usually we're thinking about resistance in different ways. So that detergent thing is just really fascinating. I mean, really, if you think about like your dish soap, like cutting through grease, it's what the drug is essentially doing at these outer layers, right? I mean, I think that's so interesting. Really very interesting. Thanks, Alyssa. I'm learning a lot today. So my question for you would be then, you touched on this a little bit earlier when we were talking about the nephrotoxicity, but why might a clinician choose one polymyxin over another? Can you give us a couple examples? And I think for the laboratorians, this is always really helpful just for context to understand why, a clinician might call down and ask for additional susceptibility testing on a given drug, or, what patients they might see, coming through with these requests or things like that. It's just a nice piece of context that I think is helpful for us to understand.
Absolutely. This is really valid. This is what we're all doing this for, is the clinical application. So I'd be remiss if I didn't just going to basically quote from the M100 some cautionary statement for this class. So basically, the clinical data for colistin and polymyxin have demonstrated very low clinical efficacy. So even, and we haven't touched on the breakpoints, but even when you do obtain that intermediate result, alternative agents are strongly preferred. So colistin and polymyxin B should be used in combination with one or more active antimicrobial agents, and consultation with an infectious disease specialist is recommended. Taken straight from a footnote in the M100. And so this is just important for really everyone involved in clinical care of patients to be cautious. And we'll when we go back to the breakpoint changes, I'll mention why. I really just wanted to make sure we touched on that point. But if you are without options and polymyxins are your only option for whatever reason that is, there are some nuances to this class. So as I mentioned previously, since colistin is associated with that nephrotoxicity, it does concentrate in the urine. So if you are going to treat a urinary tract infection, colistin would be the preferred agent. And something to note here, this is sort of a little nugget for the clinicians here, is that since it concentrates in the urine, you can probably get away with lower doses. So potentially we can avoid that nephrotoxicity. And this would be in determination with clinicians looking at the MIC and stuff, but colistin for urinary tract infections. And then for systemic infections, as I alluded to previously, given the data that's come out in the last few decades, polymyxin does appear to be safer. So it has become the preferred agent for treating a systemic infection. Also, it just has far superior pharmacokinetics. So colistin is administered as a prodrug, so it's not even active. It has to actually convert to an active form where it has bacterial killing. And it is eliminated so quickly from the body that it's often cleared before it even has time to convert to its active form to kill bacteria. So you just kind of wrap your mind around that. That's how inefficient a drug colistin is. So just really poor. So if you're reaching for these drugs, you don't have options. But so polymyxin, due to its superior pharmacokinetics, so it's being administered as an active drug, limited nephrotoxicity compared to colistin. If you're treating a systemic infection, that's our preferred agent. And then one other thing to note that kind of came out of all of this with reevaluating breakpoints was that both polymyxin B and colistin, when giving systemically, are unlikely to be effective for pneumonia due to just extremely poor concentrations found in lung tissue. And this is for both agents. There is some limited and conflicting data to use inhaled colistin, so you might see clinicians asking for a breakpoint and potentially for inhalation use. Again, this data is limited and conflicting. Could be a whole nother podcast on inhalation colistin. But yeah, so that's kind of the nuances between the drug classes and when you might reach for one over another. I hope that helps.
That does. It's super interesting.
Yes, and just kind of following that question, something that's very important to us in the lab when we do the testing and we get those calls, and we have mentioned this many times, and using the interpretation of one drug and apply that to another. A great example being tetracycline, but it's susceptible. So for polymyxins, can you actually do this? Assume the interpretation of one drug and apply that to another one?
Yes. So for per CLSI M100, colistin and polymyxin B are considered equivalent agents. So MICs obtained from testing of one can be used to predict MICs of the other.
Okay, that's always really helpful. I think it's less of a challenge for this class, but it certainly happens with the other classes, not infrequently, where someone will call down and say, hey, I have the MIC and interp for this one drug. Could I use that or assume that for another, like cephalosporin, for example? So you've touched on breakpoints a little bit here and there, but could you just take a little bit of a deeper dive on any recent breakpoint changes we should know about and maybe a little context around why those changes are made? Thanks.
Absolutely. Yeah, I think that this was one of the more fascinating changes that kind of came out of all the recent breakpoint changes we've been seeing. So this one happened in 2020. There's some great conversations out there in the clinical microbiology and the ID PharmD community about this and why decisions were reached. But to provide a little context, so if we go back actually to, let's see, if we go back all the way to maybe 2003, CLSI revised a dysdiffusion breakpoint and a new MIC breakpoint for Pseudomonas and Acinetobacter. In 2010, UCAS publishes colistin breakpoints for Enterobacteriales, Pseudomonas, and Acinetobacter. And this was previously, so in 1980, as I mentioned, they removed breakpoints. Polymyxins were no longer recommended for use, so they removed any breakpoints from the CLSI documents in 1980. So then 2003, 2010, we see some movement in CLSI and UCAST. In 2004, colistin revises breakpoints for Pseudomonas and Acinetobacter, so it decreases them. Sensitive is less than or equal to 2. And then the CLSI for Enterobacterialis just does an epidemiologic cutoff value, so isn't even willing to really commit to a breakpoint. So that was where we stood in 2014. We have an epidemiologic cutoff value for Enterobacterialis, and for Pseudomonas and Acinetobacter, we have a susceptibility breakpoint of less than or equal to 2. So there's lots of rumblings about, the new beta-lactamase inhibitors that have demonstrated superior efficacy. Colistin and polymyxin had really, really poor clinical cure rates, even at MICs that were considered susceptible. And so in light of this, and really what we saw, actually, there was a survey that went out to clinicians in 2018, and it demonstrated that in the US, polymyxins continued to be used in place of the new beta-lactamase inhibitors that were available on market that had demonstrated superior clinical efficacy. And the fear there is that we're reporting colistin as susceptible, and maybe some of these agents that are in hospital formularies are restricted. And so we're going to colistin first versus some of the newer agents. And it, again, demonstrated much poorer efficacy compared to the new agents. So this really kind of lit a fire, I think, under those in the CLSI, and saying we really do need to reevaluate this. So when they looked at that PD data, basically, can we achieve these concentrations in a patient with an infection? It really was where we saw that toxicity, efficacy overlap, and really, even when we were giving max doses of polymyxin, not achieving concentrations in the lung that would demonstrate killing. So really, all of this led to a reevaluation of the breakpoints. So now in 2020, CLSI does not even have a susceptible call. So there is no S, it's intermediate. So basically, if you get a value of less than or equal to 2, that would be considered intermediate. And this is to signal to clinicians that if you push doses and you're willing to do that, you might see some success with this drug, but it's not fully susceptible, and there's probably better options out there. So this was a pretty big deal, a change again made in 2020. USCAST and the UCAST did similar things to really kind of steer clinicians away from this class unless you have no other option. So that's kind of an overview of breakpoint changes and why they happened in 2020 and why they're important.
That is really fascinating and really complicated and just a lot to think about. I think that's I love every time we get into a discussion about essentially breakpoints and why they change. I love hearing the different reasons and stories why, because there's so much that goes into developing these breakpoints, right? And you bring up, just for the audience, you mentioned ECV, and I don't know, and correct me if I am misspeaking this in any way, but just for the audience, the ECV is the epidemiologic cutoff value. And so what that is in early essentially early trials or early collection of data of a drug against a given bug, you'll get all these MIC values, and that'll create this MIC distribution. And some math can be done that basically estimates this point called the epidemiologic cutoff value that divides this distribution into wild type bacteria, so the ones that are the MIC where the bug would probably naturally be susceptible, and then the other side of that point would be those that have acquired some sort of resistance. That information is taken into account in combination with clinical data, so things like pharmacokinetics and pharmacodynamics, and other clinical data that's collected during trials, and those things are all kind of put together to create a breakpoint. And the breakpoint ultimately accounts for all the things Alyssa was just talking about, like dosing and PK/PD. And so sometimes when we just see an ECV, it's potentially helpful information, but that could mean that maybe there's not enough clinical data, maybe there's not enough PK/PD information to really make a breakpoint for a given bug drug combo. So anything to add to that, Alyssa? Am I explaining that correctly?
That was absolutely perfect. And so, yeah, I also too learned about the epidemiologic cutoff values in 2020. I was like, I'd heard of them, but definitely dove into them there. And I think what also, matters to you all in the laboratory is also the reproducibility of being able to get that MIC. And so that's another thing that comes into play when considering those epidemiologic cutoff values. If you pick that MIC that's right on the edge there to divide wild type versus non-wild type, oftentimes it's not reproducible. And so that's where things get tricky, is where to draw that line, what concentrations can be achieved, what can the lab do. And we didn't touch on this, and I won't spend too much time, but also just to mention the susceptibility testing of polymyxins is beyond fraught with complications. They are just a real bugger per microbiologists I've spoken with. So they have cationic properties. They diffuse very slowly into the augers. They stick to everything, to the plates. And so really testing these in the laboratory is so troublesome. And I think at this point, it's really just broth microdilution that's recommended, which might be send out depending on where you are. And so and the issue there is, just to highlight this, is that if your laboratory method if polymyxin, one of these flaws of it leads to an incorrect MIC, that your risk is that you're reporting a false susceptibility. So that's really, when we think about those errors, that's the one that we don't want when you're reporting a drug as susceptible and it's actually not. So just a super tricky drug.
No, I think that's great. That's actually a beautiful segue into my next question for you, which was actually to you and Luis, just about, does CLSI offer any guidance in terms of how we should be performing susceptibility testing in the lab for these drugs? And then you already just mentioned a couple things to consider, but is there anything else you want to add to that in terms of susceptibility testing, or anything from M100 we should be thinking about, or no?
From my standpoint, I probably spoke further into than I should, and I would reach out probably to my clinical microbiologist. So I would defer to you and Luis on anything above, what I've mentioned.
I think my recommendation would be to look specifically at the comments in the M100. I don't know it off the top of my head, but I do think there are specific comments around what you just mentioned, Alyssa, with talking about broth microdilution. For example, for polymyxin B, broth microdilution being the only approved method. I think there's some other comments about if you want to do alternative methods, what to consider. And so I just think maybe worth looking in the M100 and reading that if that's something you're considering doing. Luis, do you have any experience with this?
Yes, I think we do broth microdilution for colistin. It's part of a we use a sensitizer. So we use that when if we have like for a CREs specifically, and then it has colistin. It also has in the panel we have it has Cerbaxa, Avicaz, and other drugs.
Are you manually reading those plates, or is the instrument reading it for you?
It is we manually read it, yeah. So we put it in the instrument, and then the image is produced, and then we just kind of we're selecting the MICs.
Do you notice any challenges with reading those walls? Do they look sticky or weird or anything?
When it comes to that, no, I haven't noticed any. I haven't had any challenges with reading those.
I know we did long ago when I validated that instrument for MICs in the lab I was in. We had chosen to do some manual reads for some bug drug combos just because some of them looked a little bit funny, and so we would do like a manual incubation and read them ourselves. But I didn't know if this, just based on what Alyssa said, if they would look funny in the wells or not, but that's really interesting. Yeah, so I guess that would just be my overarching recommendation, is if you're doing this testing in the lab, refer to what M100 is saying, or, you have to have some sort of broth microdilution probably in place to be able to test for this locally, which I know a lot of sites don't do. So it's just an interesting consideration.
Yes, definitely. And once again, to the audience, always check out the CLSI M100, and it's something that when you're working on the bench, you should definitely get familiar with it. And it's an easier as having it in your favorites in the computer, and you don't have to get up and look at the binder every single time you have a question. You don't have to memorize it or know the whole thing by heart. But at the very least, you know where it's at. And you get that phone call, you have a question, you just go to it. And it has, a lot of great information. So definitely you should be part of gathering your things when you're ready to work on the bench. Okay, well, as we kind of are coming to a close, I mean, I wanted to say, Alyssa, do you have anything else for the audience?
I think this is an important drug class. If you see this come down to your lab, the patient's probably without options. And so it is, good to know about, but it's something hopefully you're unlikely to see very often. But yeah, I think there's a lot of nuances in this drug class, very interesting drug class. Hopefully we'll see some new drugs come down the line. It really does have a unique mechanism of action. And the fact that it's limited to gram negatives, when we think from an antibiotic stewardship standpoint, that's just gold. We're not blasting, we're at least just targeting the gram negatives. And so I think that if we can leverage that and then limit this nephrotoxicity, also get better pharmacokinetics, so active drug concentrations where we need them to the site of infection, I think this could be promising. So I know there's a lot of development happening in this area, so maybe we'll see another resurgence of polymyxins. So that's it.
What about you, Andrea? Do you have anything else?
No, Alyssa, thanks. I feel like I have learned so many things today. So I think this is really great. I'm still munching on some of the things you said. I'm going to sit with it for a while because I feel like I just learned so many new things. So thanks.
Same here. Once again, Alyssa, thank you so much I definitely learned a lot, and I hope the audience does too. So thank you so much for taking the time to being Let's Talk Micro.
Thank you.
And that, my dear audience, it's the end of this episode. I hope you enjoyed learning about the polymyxins. As always, I enjoy sharing this information with you. These episodes are meant to really help you to break things down. So let people know that Let's Talk Micro is out there, that it's a great resource, that it's free. So share it with coworkers, share it with students, let them know. Thank you so much for the support. As always, stay tuned. Great things coming your way. And of course, if you are attending Microbe this year, hope to see you there. And as I mentioned previously, on Friday, June 14th, from 4 to 4:45 p.m. Eastern Standard Time, stop by the Clinical and Public Health Microbiology Track Hub, where Andrea Prinzi, Nicholas Moore, and myself, we're going to be there. And hope to meet you, hope to connect. So, please continue bringing that passion to what you do. It's so important. You do such great work. So, as always, stay motivated, stay safe, and of course, Alyssa,
Continue talking micro.
continue talking micro. Until the next time. Bye.